Hello everyone, my name is Dr. Bekim Sadikovic. I am the program head of Molecular Diagnostics program in the Department of Pathology at London Health Sciences. I'm also a scientific and clinical director of the Verspeeten Clinical Genome Center and a professor of pathology at Western University. For the purposes of this presentation, I'm also the co-chair of the Ontario Epilepsy Genetic Testing Program Advisory Committee. London Health Sciences Genetic Center is where epilepsy testing is being performed. Here's a snapshot of our website where you can get a lot more information about the type of work and type of testing that's being done in this lab. We are a very broad scope laboratory. We do a lot of hereditary genetic testing, somatic oncology testing, everything from single gene to full genome, including genomics and epigenomics. Ontario Epilepsy Genetic Testing Program is the first of its kind in Ontario. We are a laboratory that's helped develop that program. We are at London Health Sciences in London. We have about 70 clinical research and bioinformatics staff. We're an integrated facility that combines clinical diagnostic testing with advanced genomic research as part of the Verspeeten Clinical Genome Center. So the next few slides, I'll provide you a bit of an insight on the current state of the epilepsy testing. We've launched testing back in November of 2020. Thus far, we've completed and resulted about 353 reports. Our average turnaround time for this test is about a bit less than 4 weeks. We do advance some urgent genetic testing to within 2-week turnaround time. And at this point, out of 353 patients reported, we have 128 for which we've received the questionnaires, feedback questionnaires from the physicians. I want to emphasize it's very important for us to continue to receive these questionnaires because Ontario Epilepsy Genetic Testing Program is part of a broader scope program that is looking specifically at health system impact. And this is the type of information that we want to continue to collect to be able to provide real-time evidence for the utility of this test in the province of Ontario for our patients. As a whole, in September 2021, we're now at about 18% patients receiving a pathogenic or likely pathogenic variant as part of a report. About 28% have variants of unknown clinical significance, and about half don't have any specific genetic findings. One thing that I also want to emphasize, which is a novelty specifically for this testing program, is that as part of the new requirements for targeted panel genetic testing, we're now required to be able to report copy number alterations. This is something that's not been tested regularly historically. And I'm happy to say that about 15 to 20% of all definitive molecular diagnoses are actually those types of mutations. These are mutations that affect gains or losses of entire exons of specific genes. Here's a list of some of them. And this is what they look like. This is an example of next-gen sequencing output where we're directly from next-gen sequencing able to detect deletions of specific exons or sections of exons, in this particular case of the DPDC5 gene. These are diagnostic findings. When we look at overall the number of samples we've tested and reported out so far, vast majority are ordered for the comprehensive test that includes 167 genes. One thing that I really want to emphasize is when we look at the column of number of questionnaires completed versus number of tests ordered, you can see that we're still, lagging quite significantly behind. So this is my appeal to all of the physicians that order this test to continue to please fill out these forms. They're very important. One other key feature that I want to emphasize here is the findings with diagnostic utility. We can see that in early infantile epilepsy, we tend to see the most of this type of impact. When we look at the feedback forms, specifically diagnostic utility within a specific clinical feature, we find that patients with epileptic encephalopathy, progressions of seizures, and drug resistance tend to see the largest percentage of diagnostic utility. About a third of these patients, based on genetic tests, have significant diagnostic utility. You can see the list of the rest of them, including things like neurodevelopmental impairment, EEG, structural brain malformations, and so on. the diagnostic utility from physician feedback form by onset type. We can see that for the most part, the general onset epilepsy tends to see the highest diagnostic utility based on this test, followed by focal onset, mixed onset, and then overall is at about 15%. And finally, last category that I want to mention is the impact of patient management as per physician feedback based on a category. So as you can see, about half of the patients don't have any specific change in management. However, based on genetic test results, approximately about 30% patients will follow up with parental genetic testing or followed by the referral to other specialists. Other types of impact, we see based on the results of this genetic test is follow up with further imaging and other testing. Referrals of relatives for genetic testing. Then specific clinical management impact include things such as referral for epilepsy surgery evaluation, as well as changes in anti-seizure medication and so on. And with that, I'd like to thank you all for your attention, and I'd certainly like to thank the hardworking group at the Molecular Diagnostics Laboratory of London Health Sciences for continuing to provide the best care for our patients. Thank you.